Now it is my pleasure to introduce Dr. Martin Auerbach. He is a nuclear medicine physician at UCLA. He's going to discuss the latest in PRRT. But there is two fun facts that I would like to say about Dr. Auerbach, and I have to say I'm very impressed by his fun facts. The first one is that to disprove the saying that a watched pot never boils. So Dr. Auerbach once watched a pot of water until the water started boiling. How long did I take? And in his younger days, he once worked as a foot model. So, Dr. Auerbach, welcome.
Thank you very much. And if you want to see my feet, meet me afterwards. Always a pleasure to talk at LACNES meetings. Highly sophisticated patient population, so please I apologize in advance if I oversimplify things. I know that you are very, very sophisticated and savvy when it comes to things, neuroendocrine tumors. So I'll give you an overview of what's currently new or what is considered new. New is under apostrophes because a lot of these things have been going on for years and they're just now coming to the forefront. I'll talk about salvage therapy and then alpha therapy. I know a lot of you are excited about the alpha therapy, and then we'll also talk a little bit about combination therapies that are being researched and a little bit about dosimetry. So you've seen this slide already many times. It basically illustrates what we in nuclear medicine work with when it comes to neuroendocrine tumors. And if you imagine this being the neuroendocrine tumor cell, you have structures on the surface of neuroendocrine tumor cells that are called somatostatin receptors. There are 5 types of somatostatin receptors. Somatostatin receptor 2 happens to be the most important one for imaging and treatment. And then, so in the body, there is a hormone called somatostatin that binds to this receptor. And for imaging and also for treatment purposes, we have developed something that's similar to the somatostatin. One was called octreotide, and the one that we use for PET imaging is called dotatate. And we attach a radioactive isotope to that. And when it comes to imaging, we attach a radioactive isotope that emits photons that we can use for creating an image. And the currently available imaging tracers are dotatate. It's labeled with gallium-68. The brand name is NetSpot. Then there's a dotatate labeled with copper-64, and the brand name is DetectNet. There's also another compound which doesn't use dotatate, it uses DotaToc, and it's also labeled with gallium-68. And all of these bind to the somatostatin receptor. Imaging these days is no longer done as an octreotide scan, as was pointed out earlier. If your doctor orders an octreotide scan, tell them this is obsolete. I want a PET scan. PET scans are done as PET-CTs, where you fuse 2 imaging modalities, that is PET, positron emission tomography, with a CT. That gives you the advantage of getting molecular information about the presence of somatostatin receptors, how widespread the disease is, and with the anatomical information you can measure the size, you can localize in what organ the metastasis sits or where the primary sits. So when we do imaging, we verify the presence of somatostatin receptors on the disease apart from staging it. When we do treatment, we use the same dotatate compound that binds to the somatostatin receptor, but instead of labeling with an isotope that allows us to take a picture, we label it with an isotope that has different properties when it comes to the radioactive decay. In the case of lutetium, we have emission of electrons that locally bombard the tumor cells and hopefully destroy them. And the term that's frequently used for this combination of diagnostics and therapy is theranostics. I'm sure you've come across it many times. So when it comes to treatment, to PRRT in particular, we always want to look at the scans that the patients had, their dotatate scans. Whether it's labeled with gallium-68 or copper-64 doesn't really make a difference. Now, if somebody is a candidate for PRRT, what we want to see is dark spots, meaning there's a lot of tracer uptake in the tumor, meaning that there's a lot of these somatostatin receptors present on the tumor cells. This is usually the case in lower grade neuroendocrine tumors that are well differentiated and maintain the properties of the cells that they originated from. Now, in some patients, the density of the somatostatin receptors will be less, and then you'll see less uptake on the scan. Those are usually the higher grade, less differentiated ones. And then in the undifferentiated high grade neuroendocrine tumors, there's frequently, or in most cases, there's absence of significant somatostatin receptor expression, and you won't see any uptake on dolotate imaging. So this has also been alluded to in the prior talks. The patient referral process to PRRT is, I'd say, rarely or less frequently by direct referral from oncologists. These are usually oncologists that are very familiar with PRRT, that work in an environment where PRRT is being offered, and that are able to make that decision to send the patient to nuclear medicine. At UCLA and in most places, this is becoming the norm. You have something that's called a neuroendocrine tumor board. This usually consists of multiple specialties, and this reflects the heterogeneity and complexity of neuroendocrine tumors, including oncology, endocrinology, nuclear medicine, radiology sometimes, interventional radiology in particular, surgeons, and also pathologists that look at the actual tissue. So these, at UCLA, we meet once a month, and patients are presented. We go over the imaging, we go over the pathology, their history, what treatments they've had, and then the next best course of action is decided upon. So PRRT, you've heard that now many times. The alternate name is radioligand therapy. I won't go into any more details because you've listened to this enough. And the NETA trial, most of you are familiar with this seminal trial that led to the approval of the drug called Lutathera. So what's new? I'll start out with salvage therapy. Now that Lutathera has been around since 2018, and quite a number of patients have gone through PRRT, they are now at a point where the disease has progressed again. So what should the next step be? Well, one of the options is salvage PRRT. Salvage meaning a repetition of giving Lutathera. Now, as of now, there are no guidelines or large trial data available that would guide us in selecting what patients are candidates for salvage treatment. There is, however, a good number of retrospective data, and based on that retrospective data, and also asking around at multiple other institutions that offer salvage PRRT, the general approach is you want to have a fairly reasonable response to the first time patients had PRRT, so the first 4 cycles. And this is generally considered to be the case if disease control, meaning either the disease has been arrested, has not been getting worse, or even has been getting better, that this effect of the initial PRRT lasted for at least 12 months. And then most institutions will give 2 additional cycles of PRRT. Now, the second time round, unfortunately, doesn't work as well as the first time round, but you can generally say, based on the data that is available, the better patients did with their initial PRRT, the better they will do with salvage PRRT. And this here is actually a trial where hopefully, once the data is completed in 2026, where they're using salvage PRRT versus everolimus in midgut neuroendocrine tumors that have progressed after initial PRRT. Alpha therapy. This has created a lot of excitement. What is alpha therapy? Well, it's basically PRRT using a different radioactive isotope, a radioactive isotope that, unlike lutetium or from the earlier days yttrium-90, which decays by emitting a beta particle, which is an electron, with a radioactive isotope that decays by emitting an alpha particle. And what's the difference? Electrons are very small. They have higher energy. They kind of blow through the tissue and usually are thought to cause only single-strand breaks in the DNA. The DNA, and in this case, the DNA of the tumor cells, has two strands in a helix, arranged in a helix. If you break one strand, it's easier for the cells to repair the DNA again and the tumor cell to remain viable. Now, alpha particles, which are basically a helium nucleus, are almost 2,000 times larger than electrons. They also travel far smaller distance than the electrons do. So they get an alpha particle you can stop with a sheet of paper. So whereas electrons travel millimeters, the alpha particles only travel micrometers. So the advantage of that is that you can impart higher energy to the double-stranded DNA and cause double-strand breaks. So those are very difficult to repair, and the damage to the tumor cell is much more significant, and the killing effect should be higher. And because the alpha particle only travels a very short distance, that should minimize damage to healthy tissue that is close by to the tumor cells. So that's the idea behind using alpha instead of beta. Now, there's not much data yet. There's a lot of retrospective data, small trials, initial single patient or low number of patient case reports, but nothing, no randomized trials. So the large trials are really about to happen, some of them randomized, and I'll talk about that in a second. Sort of one of the larger trials was one that was done with actinium-225 dotatate that was given every 8 weeks. In this particular trial, they gave capecitabine, which is an oral chemotherapy agent, as a radiosensitizer. And then they treated patients that either had prior PRRT and had progressed or responded, and then they also treated PRRT-naive patients. And they achieved pretty good results with their alpha therapy. But again, this was not a randomized trial. This was a dose-finding trial with escalating doses. But overall, the information that was gained from that trial is that it worked and that it was safe. So what are the trials that are currently available? And when I'm showing you these trials that are currently available, I'm trying to include as much as possible. It's impossible to include all the trials, but I know that the LACNet's website has a very good resource to find out about trials. One of the trials that's already been running for a couple of years is the AlphaMedix trial. It uses lead-212 dotatate as the treatment agent. Again, it's not a randomized trial. It's a dose-finding trial. And then very recently, the Brazy Bio 101 trial opened up. This is a randomized trial that uses actinium-225 dotatate, comparing that to the standard of care. Standard of care meaning sunitinib, everolimus, lanreotide, and octreotide, in patients that had initial good response to PRRT and then progressed later on. And I'm happy to say that we have this trial available at UCLA, and we actually enrolled our first patient 2 weeks ago. He's actually here in the audience. And hopefully this trial will give more information and useful information to how good alpha therapy really is. There's another trial that's, Lisa informed me, I wasn't aware of that, that's opening also very soon. That's also using alpha with DOTATOC, I think. Okay, moving on from alpha to combination therapies. So combination therapies try to find out whether combining two treatments, doesn't have to be PRRT, have an additive effect or even a super additive effect in treating disease. Some of the trials that are looking at PRRT specifically in combination with other drugs, one of them is the ControlNet trial that was completed, I think, a year or two ago. And they looked at PRRT with CAPE-10 versus PRRT alone. This was done in GI midgut neuroendocrine tumors. In this case, they didn't find any difference in disease control. They also compared PRRT with CAPE-10 versus CAPE-10 alone. This was done in patients with pancreatic neuroendocrine tumors. These patients, in this patient group, those that got the PRRT with the CAPE-10 did better than the ones that only got the CAPE-10. In both groups, when they looked at actual shrinkage of disease. Those that had the combination therapy did better than the ones that did not get the combination therapy. And then there's a number of trials, again, this is not all inclusive, that look at DNA repair inhibition. There's a group of drugs called PRRT inhibitors. As I showed you earlier, what we do when we give the radioactive drugs is we damage the DNA. Now the thought is if we block the repair of that DNA, that will aid in getting the maximum treatment effect. Not much data yet available. The recent NANETS meeting had a couple of abstracts that showed promising results. So hopefully this will pan out to be helpful. And then you've also heard the radio today about immune therapy. This is a trial at, I think, at UCSF, where they use pembrolizumab, which is what's called, belongs to the drugs that are called checkpoint inhibitors. What they do is they kind of rev up your immune system to fight cancer. And this was combined either with liver-directed therapy, interventional radiology injects a drug that directly attacks the disease in the liver, or in combination with PRRT. The liver-directed combination with pembrolizumab did not show any significant effect, but there was some promising data that combining PRRT with the immune therapy does help patients. Now, these combination trials all sound kind of straightforward, but it's much more complex. Medicine is really messy. So just to illustrate that point here, this is from animal data where they combined PRRT with a checkpoint inhibitor with immune therapy, and they gave the immune therapy at different time points. So if you look at these curves here, you can see the red curve here. This is when they gave the immune therapy before they started the PRRT. And you can see this is tumor size, that the tumor shrunk significantly. Now, if they gave the immune therapy the same day as the PRRT or after the PRRT, the effect of the additional immune therapy was negligent, didn't really add anything. And these are just images for you, those of you interested, that illustrate the uptake. This is a tracer that indicates the presence of immune cells in the tumor. And you can see that only in the group that received the immune therapy before getting the PRRT, you see significant accumulation of immune cells in the tumor. So this is just a slide to really bring home how complicated it is to set up these trials. And whatever thinking you have in terms of hypotheses, it's not straightforward to translate that into clinical trials and into actual treatments. And then lastly, dosimetry is another buzzword that's been floating around. Currently, the approved dose for Lutathera is 200 millicuries for every patient. Now, patients have different diseases, right? You can have widespread disease throughout the body. You can have disease that's limited to the liver. So the question is, if somebody gets this, if these two patients get the same dose, are they going to have the same effect? Nobody knows the answer. There are some trials. This is one of them. It's called personalized PRRT, where based on a maximum dose that can be given without causing a critical dose going to the kidney in this case, whether increasing the actual administration of the PRRT drug will improve outcome. But dosimetry, with all its sexiness, is not very straightforward. It's, there's no consensus of what constitutes a ideal dose to the tumor cells. There's a lot of patient involvement because patients have to come from multiple imaging sessions to do the dosimetry. Doing dosimetry itself is, drawing regions of interest around organs. So if you have, or around tumors, so if you have isolated tumor, it's easy to draw a region of interest and measure the dose that's going there. But if you have diffuse disease in the liver, it's virtually impossible if you have very small lesions to get any significant realistic numbers. And then lastly, there's also a financial problem because companies that have an approved drug with an approved dose are very reluctant to change that because it would involve a lot of trial safety data, et cetera, et cetera. So as you can see, dosimetry is not straightforward. The good news is there's a lot of things going on, a lot of things around the corner. There are a lot of good people working, and hopefully, in addition to what we already have available, there'll be new things available to help you and your loved ones that are suffering from neuroendocrine tumors. Thank you very much.